Junji Furuse is going to talk us through how to mix and match the guidelines for treatment. We're very fond of guidelines in the West, and do they work for the East, and other difficult questions. I'm sure he'll be able to tell us. Thank you, Junji.
Thank you very much, kind introduction, Jim. And it's my great pleasure to be here. And I really appreciate Professor Chen and staff of this conference for warm hospitality. So my job today, my title is Consolidating the Treatment Guidelines and Chemotherapy for Cholangiocarcinoma between the East and West. And yesterday and today, many speakers mentioned about the chemotherapy for biliary tract cancer. So I want to review clinical trial result again and mention about the guidelines for biliary tract cancer today. Okay. So Japanese guideline published treatment algorithm for biliary tract cancer. Surgical resection is a priority to treatment for biliary tract cancer. And this surgery possibility followed by adjuvant therapy using chemotherapy, but no established standard of care adjuvant treatment. And unresectable biliary tract cancer is usually treated with chemotherapy here. And today I mention about adjuvant therapy and chemotherapy for unresectable biliary tract cancer. Some phase 3 trials are published post-operative adjuvant therapy. Gemcitabine, Gemox, and capecitabine are already published, and S1 monotherapy is under investigation in Japan. So this is phase 3 trial comparing gemcitabine versus with observation alone. Totally more than 200 patient enrollment and allocated to gemcitabine alone and observation. But unfortunately, no difference in overall survival or relapse-free survival. So gemcitabine failed to demonstrate the efficacy in adjuvant setting. And French clinical trial was a comparison between Gemox and observation, and a little bit small trial, but totally around 200 patients enrolled. And also, Gemox did not demonstrate this, positive data in relapse-free survival. And this is very famous and biggest randomized phase 3 trial, so-called BILCAP, using capecitabine versus observation. And unfortunately, not statistical significant difference in ITT analysis, but the per protocol population demonstrated a big difference in OS in favor for capecitabine. So we can see mentioned in NCC guidelines adjuvant treatment. First is just still observation and fluoropyrimidine radiotherapy and fluoropyrimidine-based or gemcitabine-based chemotherapy and clinical trial. So not so definite chemotherapy using capecitabine or something. And the Japanese guideline planning to publish in this March or April in 2019 regarding adjuvant chemotherapy after surgery. Our recommendation is no adjuvant treatment has demonstrated to improve definitively the overall survival. However, adjuvant treatment would be considered if some benefit would be expected. A little bit difficult to just recommend definitive treatment, but many doctors, surgeons want to give adjuvant setting treatment in Japan. And recently, ASCO clinical guideline was published, and in this mention, capecitabine is recommended adjuvant setting for duration 6 months based on BILCAP trial. So this is a phase 3 trial of S1 versus observation, so-called JCOC 1202 was clinical trials, and 140 patients already enrollment and last year, and the follow-up period of 5 years, but the primary endpoint can be open 2 years later, so we expect the positive data. If after the we can see we can show you the final result. John proposed us to combine the two clinical trial meta-analysis. So I would like to move to chemotherapy for unresectable biliary tract cancer. As you know, GEMS plus cisplatin is recognized as a standard of care for unresectable biliary tract cancer based on result of ABC02 trial and Japanese trial of BT22 trial, same design. GEMS is compared with gemcitabine alone. And in both clinical trials, median overall survival is very comparable, around 12 months. And we did meta-analysis of 2 randomized trials of ABC02 and BT22, and each tumor site favor for GEMS compared to GEM. So we don't separate each tumor type for GEMS in practice. And recently, 2 clinical phase 3 trials published from Japan. One is JCOC 1113, which was compared GEMS versus GEMS1 to evaluate the non-inferiority GS in overall survival. Primary endpoint was met. Almost same curve, but the non-inferiority was obtained. And but progression-free survival was favored to GS, but the response rate GC was better than GS. So discrepancy in anti-tumor activity in both 2 regimens. The other clinical trial, phase 3 trial, which was GEMS plus S1 triplet regimen comparing with GEC standard of care by a KHBO study group. Professor Dr. Ioka in this room was a principal investigator. And this trial met the primary endpoint in overall survival, but not so big difference in median overall survival, but probably longer survival were observed in triplet regimen. So finally, positive superiority was obtained. And interestingly, a very high response rate in triplet regimen, over 41% response rate. So we can see guidelines again. NCC guidelines mention about standard of care for unresectable biliary tract cancer. GEMSIS combination is still high evidence of standard of care category 1. But in Japanese guidelines, based on two recent clinical trials, GEMSIS, GEM-S1, and GEMSIS S1 triplet is recommended as a first-line chemotherapy. So S1 and GEMSIS S1 are alternative option for those people. But still, GC is one of standard of care we recognize, and we want to join a global clinical trial using GC and after GC as second-line treatment. So there are still unmet clinical medical needs in biliary tract cancer. There are some discrepancies in the recommendations in guidelines because of limited international clinical trials and no established second-line treatment and no established systemic treatment of targeted therapies based on biomarkers, including immunotherapies. This is a report about genomic characteristics of biliary tract cancers, identify driver genes and predisposing mutations, but many speakers mentioned about this mutation today and yesterday. But around 20% mutation are druggable, and these compounds are under investigation for biliary tract cancer. And I want to mention about MSI-high tumor in Japanese situation. Pembrolizumab has just approved in MSI-high tumors, including biliary tract cancer, on last December in 2018. These FGFR2 inhibitors are already mentioned. And so this is another FGR inhibitor. And so this poster is just presented in this conference for Phoenix CCA2 phase 2 study of TAS-120. Intrahepatic cholangiocarcinoma having FGFR2 gene arrangement. So this is international study, and 76 institute participants. And regarding immuno checkpoint inhibitor for biliary tract cancer, this study in Japanese phase 1 trial of nivolumab alone or in combination with GEMSIS in patients with unresectable biliary tract cancer, we did 2 cohorts, which were monotherapy as in patient with previously treated, and the other is untreated patient. So, each cohort included 30 patients, and response rate in monotherapy was a little bit low, 30.3%, and combination therapy achieved a little bit high response rate, 36%. But median OS is not bad, but not so good. Cohort A, 5.2 months, and cohort B was 15 months. So we have discussed further clinical trial using nivolumab for biliary tract cancer, but not yet decide to next step. This is pembrolizumab phase 2 keynote 158. which was presented by Dr. Ueno from Japan, but this clinical trials conducted in Asian countries. And a little bit high, many patients are included, but also a little bit low response rate, around 6%. And median PFS was only 2 months, but a little bit longer survival OS was 9.1 months. And this is another immunocheckpoint inhibitor trials for biliary tract cancer. Durvalumab alone or durvalumab plus tremelimumab in phase 2 setting, and response rate around 5% and around 10%, but durable response was achieved, and median OS was 8 months for durvalumab alone and 10 months for a combination of durvalumab plus tremelimumab. So this trial was presented at this meeting, phase trial M7824, which is targeting to PD-L1 and TGF-beta. And phase 2 trial, second line, has just started as a global international collaboration study. And first line study is planning, I've heard. So this is my summarize this my presentation regarding chemotherapy for biliary tract cancer. Capecitabine would be effective as adjuvant setting, but no recommendation is shown in recent guideline in United States and Japan. GemCis is still standard of care for unresectable biliary tract cancer, but very limited available agent for biliary tract cancer, GEM, cisplatin, and S1. Thus, there are many unmet medical needs in biliary tract cancer. It is important to conduct international clinical trials to establish global standard of care, for example, IO, FGFR2, HER2, etc. Some international clinical trials are planning in first line and second line using anti-PD-1, PD-L1 antibody, or biomarker-dependent agent. So we hope establish unified guidelines in the internationally. Thank you very much.
Thank you very much, Junji. That's an excellent summary of the current guideline situation. Any questions for Junji? If I could just say, perhaps ask the people here, what guideline would you generally follow? Would you follow the NCCN, the ESMO guideline, or conceivably even the Japanese guideline? What do you use here in Taiwan? Anybody like to?
I think in most of the hospitals in Taiwan, they try to adopt the NCCN guideline. Yeah. But usually NCCN guideline, they including so many things.
Yeah.
So
no, they're deliberately left.
Probably concept is different. NCCN is a little bit consensus guideline, and Japanese guidelines are based on the clinical trials. So ESMO guidelines, but not the latest published, in probably before bill caps.
Yeah. Yeah, no, ESMO are more like the NCCN. They're more permissive. They allow you to do what you want, really. Yeah. Okay. Thank you very much.
Okay, thank you very much.
Thank you.